Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Senese. Welcome to the show. Hey, if this is your first time checking us out, or if you're watching us on YouTube, LinkedIn, Facebook, X, or Kick, welcome to the show. Be sure to like us, subscribe to us, do all sorts of things. We like it. Hey, also, if it's your first time, be sure to check out our website at uronurse.com. Best place to go to learn more information about the show, what upcoming shows are there. Visit our great sponsors and our other podcasts. We got a bunch of them now. Also, this best place to go to check out all of our past episodes, 154 of them. So always there every time, easy to find place right on our website. Now, if you like to listen to us in your car, that's not a problem. We get this thing out to you about a half hour after the show ends. All of our past episodes are also available in audio form. Just subscribe on podcast, Apple Podcast, Spotify, iHeart, Amazon Music, or YouTube Music, and have them delivered right to your mailbox. Hey, just a reminder, this week's episode changed. Yeah, the Dr. Siegel, who's going to be talking about Pluvecto, had a conflict for today, so we went and decided to go back to our original plan, which was our sexual transmitted infection module. Since there's 3 of these, we're going to go up to part 2, which is module 1 and 2. It's split into 2. We'll have 2 next week, followed by Dr. Pluvecto's talk the following week. So, hey, it's going to be a great show. Again, Kirsten Trudeau talked about this last time. She's the same speaker for all 3 of these. She's a nurse practitioner who works in infectious disease, and UroNurse, in conjunction with my CME, is able to provide credits for you this. So afterwards, maybe 5 or 10 minutes after the show ends, I'll have that change on the website. So you can go in there and click the button to get your CMEs, or CNEs, or whatever you get. They're available free of charge. So take advantage of that. So let's get going with our show and take it off right now.
Hello, welcome back to the module series for sexually transmitted infections, essential knowledge for healthcare providers. This is module 2, part 1 from the Kentucky Infection Prevention Training Center. And I'm Kirsten Trudeau, and I'm one of the nurse practitioners here at the KYIP Training Center. Funding for this presentation was provided by the Kentucky Department for Public Health. Content includes discussion of unlabeled use of products. I have no financial interests or other relationships with the manufacturers of products. No commercial support was provided for this educational activity. So this builds on our previous module 1. So in this module, part 1, we're going to review STI epidemiology in the United States. Identify and describe syphilis, trichomonas, herpes simplex virus, and human papillomavirus. And then we're also going to determine appropriate screening, testing, and treatment for each infection. So we'll start off with syphilis. So as you can see, since 1941, there has been a steady decline of syphilis with a little bump in the 90s and then going back down in the 2000s. But you can see around 2015, 2016, we started to see an increase in syphilis. And so that increase is concerning for us as far as syphilis cases and congenital syphilis as well, which we'll talk about later. So you can see here, this map is pretty staggering. The trends, the rates of syphilis have definitely increased since 2014. With the lighter shades being on 2014, the lighter shades showing throughout most of the United States, lower rates of syphilis. And then the map on the right in 2023 showing a lot more of those blues and darker blue areas indicating higher rates of syphilis throughout the United States. And you can see here the difference between males and females. The rates in males are definitely higher, but then also we definitely still have syphilis in females. The age ranges are pretty widely distributed, the 20 to 24 all the way through, even into 45 to 54 and 55 to 64, you still see some pretty significant rates in those age groups as well. So syphilis is caused by Tryponium pallidum, and it is classified as primary, secondary, latent, and tertiary syphilis. So it's typically transmitted through genital mucosa, but it can occur orally, anorectally, and through cutaneous lesions. It can also occur through vertical transmission from mother to baby at any stage, and this is a bit different than sexual transmission because that most often occurs in early syphilis. So here we have syphilis, the great imitator, is what it's sometimes referred to. So we start out with primary syphilis, and this occurs about 2 to 3 weeks after exposure. Often we see a chancre at the site of transmission or inoculation, and this can be oral, penile, perianal, those regions. And then some can have painful anogenital lesions. And then also the regional firm lymphadenopathy, and this is typically in proximity to those lesions. So sometimes this can be overlooked and thought to be something else. People don't often think that automatically that they have syphilis, which is also why it's called the great imitator. So, as we move through to secondary syphilis, about 4 to 10 weeks after the chancre, um, people can start to have generalized, typically non-pruritic rash. They can have lymphadenopathy, malaise, and fever. They can have these little um, wart-like things called condylomata lata. They can have alopecia and visceral organ involvement. So moving on to latent syphilis is it's broken down into early latent and late latent. So when you get to latent syphilis, there's no signs of symptoms or disease, but the disease is still in the body. So for early, the infection is less than 1 year in duration, and for late latent, the infection is greater than 1 year in duration. So in particular, for early, any of these seroconversions, so a sustained fourfold increase in titers in a previously treated person for syphilis, if they have symptoms, any contact with infected sexual partners, and or any documented testing with exposure all within the last 12 months, that would fall in the early latent category. And then for late latent, all of the testing reactive with no past diagnoses, no clinical signs of syphilis, and they just don't meet the criteria for early syphilis, this would fall into that late latent, greater than 1 year in duration category, which is important when it comes to classifying and determining treatment and things like that. And then we can move on to tertiary syphilis. So some people will remain in latent syphilis, but about 30 of these cases will progress to tertiary syphilis. And within this stage, there are lots and lots of complications: ocular syphilis, otic syphilis, latent neurosyphilis, cardiovascular syphilis, and gummatous disease. And interestingly, about tertiary syphilis, this can occur up to 50 years after the original infection. So it's a super long time if someone is not treated, that they could have this infection in their body and not know until it turns into tertiary syphilis, could potentially decades later. So types of testing for syphilis, we have dark field microscopy. So this is less frequently used now. People don't typically have those types of microscopes in their clinics. More often now, we are seeing serological testing, so troponal testing and non-troponal testing. So troponals would be your EIAs, your CIAs, your TPPAs, and your FTA ABSs. Your non-troponals would be an RPR and a VDRL. There's also some point of care tests and then an in-home test for antibodies. Something to consider with more in-home tests becoming available. This is really great because then people can test for syphilis, but we have to decide how we're going to track and what we're going to do with that information. So I've heard some examples of maybe some home tests eventually having like a phone connection that might, when you test, it plugs into your phone and the test results go straight to the health department. So it's just going to be a matter of, we give the ability to test at home, but how will we track that and how will we treat those people when we do have a positive? And this is just another screenshot from the CDC screening recommendations. Again, I really like this layout. Now, this is particularly for syphilis, so looking at women, pregnant women, men who have sex with women, men who have sex with men, transgender and gender diverse, and persons with HIV. And so the CDC also has a wonderful algorithm that can be applied when screening for syphilis using the serologic test because it can be really confusing. So there's a traditional algorithm and then a reverse sequence algorithm. So if you do your non-troponal serological testings, your qualitative RPR or VDRL, you determine if those are reactive or non-reactive. If it's non-reactive, syphilis is unlikely. If it's reactive, then you would jump to your troponal serologic testing. If that is reactive, then they likely had previously treated or untreated syphilis. If it's non-reactive, then syphilis is unlikely. Now, the reverse sequence algorithm is to do the troponal serologic testing, the EIA or the CIA. If that is reactive, then you would do a non-troponal serologic testing, your quantitative RPR or VRDL. If it is reactive, they likely have had previously treated or untreated syphilis. If it's non-reactive, you could do the reactive second troponal serologic test, or you could do the second troponal serologic test if it is reactive. Again, previously treated or untreated syphilis. If it's non-reactive, then syphilis is unlikely. But if they are at risk for syphilis, you would repeat the RPR or VDRL in several weeks. And prozone and biologic false positives should be ruled out. Current syphilis treatment guidelines. So syphilis is a curable STI. And the treatment differs based on which stage you are in. So you have primary and secondary syphilis is treated with benzathine penicillin G, 2.4 million units intramuscular in a single dose injection. And then for latent syphilis, it also depends on whether or not you are in early latent or late latent. So for early latent, benzathine penicillin G, 2.4 million units IM in a single dose. And then for late latent, we have to bump up a bit to benzathine penicillin G, 7.2 million units total, and it's administered as 3 doses of 2.4 million units IM each at 1 week intervals. So current syphilis treatment for tertiary syphilis, if there is no evidence of neurosyphilis, then you would do benzathine penicillin G, 7.2 million units total, administered over the 3 doses of 2.4 million units IM each at 1 week intervals. But if you do have the neurosyphilis, ocular syphilis, or otosyphilis, that's when we're talking an admission for aqueous crystalline penicillin G. And this is 18 to 24 million units per day, administered as 3 to 4 million units IV every 4 hours or a continuous infusion for 10 to 14 days. Now, what if you have a patient who has HIV and also has syphilis? So the treatment for these folks is the same as a person without HIV, but do know that they are more likely to have neurologic complications and have a higher likelihood of treatment failure. if they are HIV positive. Now, with treating syphilis, be aware of Jarisch-Herxheimer reaction. So this is a reaction to the initial treatment of syphilis, and it's usually within, it's always within the first 24 hours of treatment. It can often be confused with a penicillin allergy. It can exacerbate that secondary syphilis rash and sometimes cause hypotension and chills. Can also have fever, malaise, nausea, vomiting, which are more common symptoms. So this is something to look out for, and definitely make sure that you're not confusing it with a penicillin allergy, but particularly be aware of the time frame. If it recurs in the first 24 hours, it's likely this Jarisch-Herxheimer reaction. So what if someone does have a penicillin allergy? You notice that there weren't a lot of alternatives when we were talking about treatment. But in this particular case, for primary, secondary, or early latent, there's the option for doxycycline and tetracycline regimen, ceftriaxone is also an option, but really there's another option to do penicillin desensitization as one of the ways to be able to treat them most effectively with the benzathine penicillin G, if that is an option for them. So late latent, same thing. We could do the doxycycline or tetracycline. Ceftriaxone is possible, but there's just not an optimal dosing that has been determined yet. Also consider penicillin desensitization, but in this case, we really should contact a specialist. And then for tertiary, really just jump straight to contacting an expert or specialist in treating syphilis. For pregnant women, we would want to do penicillin desensitization if we can. But again, in this area, in this stage, I would definitely consult a specialist. And for neurosyphilis, there's just limited data for treatment with ceftriaxone. Again, with pregnant women, penicillin desensitization as well. For post-treatment testing and follow-up, the non-troponal test, the RPR or the VDRL, and same type. The goal is to see a 4-fold or greater decrease in non-troponal titers. So the schedule for this, for if they have primary or secondary syphilis and they do not have HIV, then you can re-examine and draw titers at 6 and 12 months and allow a full 12 months to see that decline. If they're HIV positive, you want to re-examine and draw titers at 3, 6, 9, 12, and 24 months, but allow a full 24 months for it to decline. Now, if they're in latent syphilis and they do not have HIV, you would want to re-examine and draw titers at 6, 12, and 24 months. For HIV positive patients, you would re-examine and draw titers at 6, 12, 18, and 24 months, but allow a full 24 months for decline regardless of HIV status in the latent syphilis. Then for neurosyphilis, ocular syphilis, and otosyphilis, there should be a normalization of RPR or VRDL titers that correlate to CSF normalizing. So whether or not, so this is with in persons who do not have HIV, or if they are HIV positive and on antiretroviral therapy. So in this case, you could really just monitor those RPR and VRDL titers. You would not need to follow up with any further CSF testing. So you would just follow the titer monitoring guidelines above for monitoring those titers. So what is the fold decrease? So you can see here that a 2-fold decrease would be like going from 1 to 32 to 1 to 16. Now we set our goal as a 4-fold decrease. So that would be an example of going from 1 to 32 down to 1 to 8. An 8-fold decrease would be going from 1 to 32 down to 1 to 4. So your goal is to see at least a 4-fold decrease. The management of sexual partners, typically this syphilis is transmitted with a mucocutaneous lesion when that is present. So you would really want to have, you would want to evaluate and test if that's recommended for all people who have had sexual contact with a person diagnosed with any stage of syphilis. Now, let's talk about congenital syphilis. So, as you can see, since 2014, the rates of congenital syphilis have definitely gone up. We were below 1,000 cases per 100,000 in 2014, and we have moved, excuse me, we were below, our rate was below 1,000 in 2014, and now we have bumped up to about 4,000 cases in 2023. So congenital syphilis can cause many devastating effects. You can have a miscarriage, a stillbirth, prematurity, and/or low birth weight. There can even be death after birth. Manifestations to these babies could have bone deformities, anemia, which is severe. The liver and spleen could be enlarged. They could also have yellowing of the skin and eyes, which would indicate jaundice, meningitis. They can also have a rash on the skin. So the thought is, or the recommendations are to screen pregnant women at the first prenatal visit, 28 weeks, and again, at delivery in areas with high syphilis rates or other risk factors for syphilis. Now, according to the CDC, maternal risk factors for syphilis during pregnancy, that includes sex with multiple partners, sex in conjunction with drug use or transactional sex, if they have late entry into prenatal care, so like if their first visit was during the second trimester or later, or if they had no prenatal care, if they use heroin or methamphetamines, if they are incarcerated or their partner is incarcerated, or if they have unstable housing or homelessness. Okay, so moving on, we're going to talk about trichomonas, also referred to as trick. So trichomonas is a protozoan parasite. And there were about 2 million cases in 2018 per the CDC. There about 70% of cases are asymptomatic. It is more common in females than males, particularly older women than younger. So clinical manifestations here, females can have inflamed genitals, including itching, burning, pain, or redness. Can also have dysuria, vaginal discharge with a fishy odor. Males can have itching or irritation of the urethra, dysuria or burning with ejaculation, and also can have penile discharge. And for both, intercourse can be uncomfortable when trichomonas is an issue. So testing for trichomonas for women, the NIAT is preferred. You could do the clinician-collected endocervical swab, clinician-collected vaginal swab, or a female urine specimen. There's also the option for wet mount microscopy as well as a culture. For men, you can also do an NIAT with urine. You can also do a culture, urethral swab, urine sediment, or semen to test for trichomonas. Screening recommendations for trichomonas, you can see here. This is screening women and persons with HIV. Treatment guidelines for trichomonas. So this STI is curable. For women, we would do metronidazole 500 milligrams 2 times a day for 7 days. For men, we would do metronidazole 2 grams orally for a single dose. And the alternative for both would be tinidazole 2 milligrams orally for a single dose. Trichomonas has a high rate of reinfection, so we want to retest 3 months after the initial treatment in sexually active women. And if we're unable to retest in 3 months' time, then we'll retest at the next visit within 12 months. All right, moving on to human papillomavirus. So this is the most common STI in the US. 85% of people at some point in their life will get HPV, and it can cause infections anywhere the virus was exposed, including the cervix, oropharynx, and anogenital. So it's most often asymptomatic and self-resolving, but some can be persistent and lead to devastating outcomes like precancer, cancer, and anogenital warts. About 36,000 people in the U.S. diagnosed with in the U.S. are diagnosed with an HPV-related cancer annually, and the HPV vaccine is thought to prevent 90% of cervical cancers. So for types of HPV, you can have human papilloma low risk type or the non-oncogenic. You can also, so these would be the HPV types that cause 90% of them cause genital warts, typically caused by types 6 and 11. And then these HPV causing genital warts can occasionally cause lesions in the oral, upper respiratory, upper gastrointestinal, and ocular locations. And for recurrent respiratory papillomatosis, a rare condition, this is usually associated with HPV 6 and 11. Now, those high-risk types, the oncogenic types, these are your HPV type 16 and 18, and those account for about 65 to 70% of cervical cancers. The HPV types 31, 33, 45, 52, and 58 cause approximately 10% of all HPV-associated cancers. So this is a graph showing the difference between males and females with new HPV-associated cancers annually. So these are the cancer types. The females, you can see the majority, 46% is cervical cancer, followed by 20% with anal cancer, 17% at vulva cancer, 14% at oropharynx, and 3% at vaginal cancer. For males, the majority you can see is 82% of them have oropharynx cancer related to HPV, 12% anal cancer, and 6% penile cancer. So this really just shows how HPV can affect both males and females. And the good news is that the HPV vaccine is available for both male and female. So diagnosis, anogenital warts is usually a clinical diagnosis, may need a biopsy, but then cervical cancer screening is done through cytology. They'll do a pap smear on a cervical specimen. There's also HPV testing with molecular testing on cervical specimens, and they may co-test with HPV and a pap smear cytology, and all of that is depending on what age group and you fall into. So HPV screening recommendations, you have HPV, cervical cancer, and anal cancer screening, and the CDC breaks down their screening recommendations by women, pregnant women, men who have sex with men, transgender and gender diverse people, and persons with HIV. And you can see within these categories, like for women, it breaks it down by age. And then it also breaks it down by whether or not they're just doing cytology or if they're doing co-testing. And then, of course, for the other categories, if there's a concern for rectal cancer for men who have sex with men, then we would be doing that exam and then testing for HPV there as well. So for HPV prevention, the best ways to do this is to limit partners, use of condoms, and of course, vaccinate for HPV. Vaccines, routine vaccination starts at age 11 to 12, can be started at as early as age 9. Catch-up vaccination would be ages 13 to 26 if they're not adequately vaccinated. And then beyond that, some adults between 27 to 45 years, if they're not adequately vaccinated, this would just be done under shared clinical decision-making. One other thing to note here, that the age and timing will determine the number of doses needed. So if the series is started before their 15th birthday, they will only need 2 doses, 6 to 12 months apart. But if the series is started after their 15th birthday, between 15 to 26, or they are immunocompromised, they'll need 3 doses at a frequency of 0, 1 to 2 months, and then lastly at 6 months. And then again, if they're between 27 and 45, then shared decision making should be implemented. And now we can talk about herpes simplex virus, or HSV. So HSV2 is more common for recurrent genital warts. Many undiagnosed, either asymptomatic or unrecognized symptoms. Seroprevalence has improved from 18% in the early 2000s, from ages 14 to 49, to about 11.9% in 2021. But there's still about 18.6 million people living with genital herpes from HSV2, and females have a twofold higher prevalence than males. Now, HSV1 was originally thought to be the most common cause of cold sore, and they have seen some increase in anogenital warts caused by HSV1, more likely for first episode genital warts now. This was previously for HSV2, but several million people with genital herpes, this is from HSV1. For HSV transmission, a person who is actively shedding the virus who has close contact with another person via mucosal or epithelial surface or genital or oral secretions are at risk of transmission. Transmission can be of both types, of HSV1 and 2, can be extragenital. And this can also be perinatal transmission at delivery, which is why we should definitely be screening our pregnant patients. HSV2 is often transmitted during asymptomatic shedding. For HSV clinical manifestations, the onset of symptoms tends to be about 4 days, ranging from 2 to 12 days. The first clinical episode is defined as the first clinical episode with symptoms. So they may have had an asymptomatic acquisition prior to, but this is their first episode with actual symptoms. Now, the primary genital infection is the first infection of either type without antibody presence, and without antivirals, symptoms last about 3 weeks. Now, a non-primary infection, this is an infection with HSV after already having antibodies to the other type of HSV. These symptoms tend to be milder than the primary infection. And if you have recurrent symptomatic infection, this occurs with known diagnoses of genital HSV, tends to be more mild and localized symptoms, resolution in about 3 to 5 days, and they may have some prodromal symptoms 12 to 24 hours before. For HSV testing options, there's viral testing, and NIAT is preferred. There's a viral culture, an antigen detection, and a cytologic examination option. There's also serologic testing, the type common serologic testing and type specific serologic testing. So when there is a sample, when sample is from a lesion, adequate sample is needed. So you would have to scrape the base of the lesion. If the vesicle or pustule, if there is a vesicle or pustule, it will need to be unroofed to get the swab of the base of the ulcer. So that's when you are doing your viral testing. Now, the serologic testing, the type common, is just going to tell you whether or not they have herpes simplex virus. The type specific is going to be more specific on HSV1 or 2. And these are the CDC's screening recommendations for HSV. You can see the breakdown for women, pregnant women, men who have sex with women, men who have sex with men, and persons with HIV. So the treatment for HSV, it's important to know that this is an STI that's a lifelong condition. And the treatment varies based on whether or not this is their first episode or if this is recurrent. And there are several different options. So you can see that the first clinical episode of genital herpes, we can treat with acyclovir, famciclovir, or valciclovir, with the correlating dosages and duration listed. The episodic therapy for recurrent HSV2 genital herpes, you can see here that, again, we can treat with acyclovir, famciclovir, or valciclovir, but again, the dosing and the frequency and duration is different. So it would really depend on whether or not it's first episode or if it's reoccurrent, and then choosing appropriately within these recommendations. Now, for suppressive therapy, this is suppressive therapy of recurrent HSV2 genital herpes. So the recommendations, again, we can use any of those, acyclovir, valciclovir, famciclovir, but the frequency, dosage frequency duration is different based on suppressive. So suppressive is going to be something that's taken, continuously and not just for a short dose duration. Another thing to note here is that people with HIV are at higher risk for more severe and prolonged cases. So treatment recommendations are different for that population. So you can refer to the CDC's STI treatment guidelines for that. Now, moving on to neonatal herpes simplex virus. So this is a serious infection this is why we need to screen our pregnant patients for HSV. So HSV infection in a newborn between birth and the first 28 days of life. This is classified as neonatal herpes simplex virus. In the US, this occurs in about 1 in 3,000 deliveries, and 85% of transmission occurs intrapartum. The other 15% is intrauterine or postpartum exposure. So clinical manifestations would be skin, eye, and mouth lesions. They can have disseminated disease, isolated CNS disease, lower birth weight, and gestational age. And unfortunately, there can also be infant mortality. So prevention is to screen pregnant patients, have suppressive therapy, and also have possible C-section in the case that there are lesions present. So some key takeaways here: syphilis cases are increasing and leading to an increased cases of congenital syphilis. Many STIs can be asymptomatic, which supports following screening guidelines to capture those patients. HPV is the most common STI in the US, but is often asymptomatic, and screening during pregnancy for STIs can prevent negative outcomes to the baby related to STIs. And these are my references. And that is all I have for you today. And you can check out Module 2, Part 2, to finish up the series on sexually transmitted infections, essential knowledge for healthcare providers.
So that was really good. I think that's a great review of things. I did get one question that came through. Katie Bertel asked about any problems with insurance coverage for patients. So I looked it up real quick on ChatGPT, and according to the Affordable Care Act, most plans are required to cover preventative services like syphilis screening for pregnant women and people at risk without copay. Medicare covers syphilis testing for pregnant people and those at risk, and Medicaid also covers testing if medically necessary or recommended. And treatment, usually the course of antibiotics is almost always covered if you have insurance and it's medically necessary. So I hope that was some help. Thanks for the question, Katie. A couple things to talk about. Number one, you may notice I got a different backdrop. So if you noticed it, let me know if you like it or not. What happened is I actually decided to invest in what's called a green screen, sort of what the news people use on television, so that you can have any backdrop that you want and you can change it. So you'll probably notice it changing a little bit as I try to figure out what I like the best and what looks the best. My other one was getting kind of worn out, and it was also difficult to set up and take down, where this one goes up and down like a movie screen. So it's much easier to change my office into an office for broadcasting versus working in for when I share with my wife. Katie said she likes it. Great. Glad to see that I've got some likes on it. So the other thing, again, part 2 will come up next week. We're going to do the part 2 of this. It's a shorter episode than this one. I think it's about a half hour or so. So I'm going to tell you guys right now, those that are lucky enough to be watching this or even watching it on demand, I've got a huge announcement to make of something that's coming up in August. So it's going to be huge. I'm going to make the announcement next week. I'm going to do it at the very beginning of the show. I know some of you like to tune in a couple of minutes late. You might want to tune in live right on time, but it's going to be a big announcement. I think you're going to like it. I'm really thrilled to do this, and I think it's going to be a big plus for us. So another addition to the UroNurse community. So keep that one in mind. But you got to get there early because I'm going to do it first thing. Here's a little tag for next week's show.
This activity provides clinical guidance on mpox, bacterial vaginosis, and vulvovaginal candidiasis. It covers diagnosis, treatment, screening practices, and prevention strategies, including vaccines, self-collected testing, and doxyPEP. Designed for healthcare professionals, the presentation emphasizes evidence-based approaches to sexually transmitted infection care and highlights the importance of extragenital testing and partner treatment to reduce reinfection and improve public health outcomes. Join us on July 19th at 9 a.m. Central Time to learn more.
So that'll really wrap it up. I mean, you talk about everything covered under the STI guidelines. It's all there. This has really been a good, strong coverage. Some interesting things. Syphilis, I had read an article that in the nursing homes, it's gone up 52%. So be careful who you think you shouldn't screen. Grandma and grandpa in the nursing home are doing more than just playing cards. So that's a word of warning. The other thing with infectious disease and all these sexually transmittable diseases is it's kind of interesting sometimes, those of us that have been in practice as long as I have been, is to hear the stories people give for why it happened. They always got an excuse. I always kind of thought that, either you come to your healthcare worker or your priest, and we get all the confessions either way. So, but they're interesting stories. I'm sure a lot of people could share some. Wow, it's allergy season. It's killing me today. But it's always I went to a bachelor party and we paid for her, so of course I had to try it. Always the crazy things. But anyway, stay safe out there. The world is a crazy place. With that, we're gonna call it a day. And all of you guys that joined us live, great, glad to have you on board. Those that are watching it on demand, make sure you check out our early warning for that episode coming up. The very beginning of next week's episode, we're going to have that big surprise for you. Until then, we've got a beautiful day here in Lake Delcarlia, where I live. It's in Indiana, just south of Chicago. The sun is shining. The heat is finally broken, so it's not so doggone blasted hot. And I got a boat that's calling me for some fishing.